next talk is Intra-Articular Treatment for Dr. Wisal Almosawi. Dr. Wisal is a radiologist based in Sydney South, New South Wales. She completed her radiology training in Prince of Wales and Prince Henry Hospital in Sydney. She trained further experience in Sydney through the radiology fellowship with RANZCR. And she had previous experience working with pediatric imaging specialist at Westmead Pediatric Hospital, and later as a staff specialist at the St. Vincent Public and Private Hospital. She was also managing radiologist at Carina Private Hospital. Dr. Almosawi, she is now the managing radiologist at Loomis Imaging, Sutherland, and reports for Loomis Imaging, Carina Private Hospital, and Loomis Imaging, Karimba. She has special interest in breast imaging, women's health, and intervention procedures, and enjoys teaching staff and students. Welcome, Dr. Wisal. Thank you.
Thank you very much for the invite. It's really a privilege. Thanks a lot. I'll try to make it very short and very simple. And this presentation is mainly actually for GP. So the objective of the talk is what GPs want to know, which is when to refer patient for injection, what imaging guidance, and I get that quite a lot, and sometimes they get confused what modality for what joint and why. How long does the relief last, and is it safe to inject? How often can we do it? And when should I refer the patient to the timing of the injection? So modalities, we're all aware of it. Mainly we use ultrasound. We used to use fluoroscopy. We hardly use it anymore because of radiation. CT guided injection, I do quite a few of these. And with the new machines, it's a very minimal radiation exposure because we only choose like 1 millimeter slides just for localization. What are the medication? We're probably all familiar with corticosteroids. It's been there for a long time, and it's probably one of the safest. Hyaluronic acid, which is like what we use now is the Flexa. And with this one, we usually do 3 progressive injections 1 week apart. So it's usually 3 weeks interval. PRP, which is becoming very popular now, and I'll go through that. We use sometimes just local anesthesia, just marking, just as a diagnostic measure to we know if this joint is what's causing the problem and the reason for the pain. Stem cell therapy, mainly for knees and hips, and dextrose therapy. So for example, it's very commonly injected into the knee, and Dr. Rabia asked me to focus on knee and hip mainly, but we inject every joint in the body. The beauty of using radiology, and I try mostly to do hips because it's a deep joint and it's not easy to palpate. I usually do them under CT guidance. And the good thing of that, if you notice, okay, that's the marker, I guess there. So this is where the femoral bundle is, where the artery, the vein, nerves, what have you there. So if you do it blindly, you might go there and injure something. You don't want to go through muscle as well. So you try to approach it through fat planes in between the muscle to cause minimum damage and intervention. So we put the needle there, we localize where we're going, we know exactly, we have CT fluoroscopy. So I put the needle, I know exactly where my needle is. Sometimes I put a tiny little amount of contrast or even just air. If they're allergic to contrast, I know I'm in the joint. When they contrast or the air moves freely within the joint capsule, I know I'm inside the joint. You don't want to inject outside the joint because there's no benefit of the injection. You don't want to inject into the muscle because, let me control this here. You don't inject with inside the muscle, you end up with a granuloma formation or abscesses, or it's more risk. So that's why I always put a little bit of contrast just to make sure it's flowing freely within the joint. We do a lot of injections for the knees as well. If there is a small amount of fluid in the suprapatellar bursa, I usually choose ultrasound. It's straightforward, no radiation, short time. You just go suprapatellar, you inject again in real time. You see the tip of the needle, you see the medication flowing freely within the joint, so you know you are in the right space. Also, when we scan with ultrasound, whether there's a Baker cyst, straight away I'll try to aspirate the Baker cyst and put a little bit of cortisone and local anesthesia there, because sometimes combined effect, this can cause more pain or that can cause more pain. Sometimes we're doing diagnostically. So I inject the Baker, aspirate and inject the Baker cyst first. If that relieves the pain, that's it, we stop there. If the pain is still there, we go back and we do the joint injection. And the beauty with that as well, if there is fluid in the joint, I always aspirate the fluid before I inject with PRP, with Euflexa, with cortisone, because the presence of fusion, first it causes tension, increase the pain, and second, it will dilute your medication. So it will minimize the effect. So always aspirate the fluid before you inject anything into the joint. Again, the beauty of doing it with imaging, I'm not injecting it into the infrapatellar bursa, I'm not injecting it into the quadriceps tendon and causing more damage than benefit. We do a lot of injection. I'm only choosing 3 joints, which are the most commonly used joints for injections. So the shoulder, we do glenohumeral joint quite often, especially for adhesive capsulitis. We can do hydrotherapy, where we use a larger volume. We mix the cortisone with local anesthesia, with normal saline, dilate the capsule, sometimes even rupture the capsule to give more range of movement. Or just for osteoarthritis. We also inject the suprapatellar bursa. So if the pain is causing by bursitis or tendinitis, we inject into the suprapatellar bursa. But if the pain is osteoarthritis, then we inject into glenohumeral joint. Sometimes we inject the AC joint, and sometimes we inject into the biceps tendon sheath. So it depends where the pain is. Corticosteroid, which, as I said, is the most commonly used. It's a normal hormone released by the adrenal gland, so it's a mimic to a normal hormone. What it does, it just helps to lower the level of prostaglandin and downplay the interaction between special white blood cells as an immune response to pain, which cause inflammation and cause more pain. So I always tell them what we try to do with corticosteroid is breaking the cycle where pain causes inflammation, inflammation causes more pain. So we're trying to break that cycle. That's why we mix the cortisone with long-acting local, which is Marcaine, just to ease the pain and ease the inflammation. Advantages of corticosteroid, which is the most commonly used one, is it's inexpensive, it's readily available, it's very potent anti-inflammatory agent, it reduces synovitis, and as I said, decrease cytokine activity, and it induces rapid pain relief. So if we want a short-term rapid pain relief, especially for sport people, where they have a game in 2 days or something, so that's when it's used if you want a rapid relief. This has advantage as temporary effect. It lasts, they say 8 to 12 weeks. Usually my patients, sometimes 3 to 6 months, they can benefit from it. It again depends on the severity and how your body will interact with the cortisone. Sometimes there is a minimal post-injection flare-up. Hyaluronate, which is Euflexa, we're doing more and more of these, and as I said, we do it in 3 weeks, executive weeks, 1 week after the other. It's a very potent synovial proliferative agent, so it helps with the lubrication and work as a shock absorbent as well. It has anti-inflammatory effect, it's analgesic, and also it's a chondroprotective effect on the articular cartilage. And that's why it's now actually, a lot of them get referred to us by orthopedic surgeon. It has a little bit of minor side effect compared to cortisone, for example, because at the beginning, there will be a bit of pain, joint swelling, skin reaction, sometimes a pseudoseptic reaction, where the joint become tender, wet, swell. It looks like as if there is septic arthritis. It is not a septic arthritis, it's just a really strong inflammatory response to the medication. I mean, there's a risk of septic arthritis, but it's minimal. So the advantages of your Flexa, if we compare it to cortisone, it has a longer effect. It can last 6 months to a year, which is a good outcome, and has a very good safety profile. Disadvantage, it's very expensive, and it doesn't start straight away. It needs a couple of weeks before you can notice the effect of it. PRP, I know the lecturer before me said it's not common, but actually we're using it more and more now, and it's proven to be very effective. So the plasma, they take blood from the patient, they put it in a centrifuger, they take a highly concentrated platelet in the plasma, and we take it and we inject it into the joint. So what it does, it has growth factor. It's capable of stimulating cellular growth, increase the vascularity in the joint, proliferation, tissue regeneration, and collagen synthesis. So mechanism, as we said, it's a platelet concentrate. It has a growth factor, which stimulates healing. It's anti-inflammatory and cartilage support. Some of the disadvantages, again, it is expensive. It needs a centrifuger, so not every practice can use it. There is still ongoing trials to see the evidence-based benefit from it. But with using it more and more, we see more benefit. So as I said, they take blood from you, they put it in a centrifuger, they take the concentrated plasma, and we inject it back into knees and hips. Actually, they're using it now for a lot, like they're using it for cosmetic reasons to increase the collagen. They use it for hair growth. They're using it for soft tissue injuries, plantar fasciitis. So there's more and more use for PRP. A stem cell? Seriously? I'm not even at, okay. I'll go through a stem cell therapy quickly. They take from fat, they take it from iliac bones, what have you, and they centrifuge it and re-inject it. Okay, so I'm not going through this. A lot of joint we can inject. The other one which we're using now is dextrose therapy. It's the same process. So we take 12.5 to 25% concentration. They inject it into the joint, and usually this one we use it when there's contraindication for other injectables. Sorry. So what are the complications for intra-articular injections? Infection, which is very rare, but it is there, and everything has to be sterile because we're getting inside the joint. They usually post-injection flare-up. Sometimes if you don't know where to inject, and you inject under the skin, you end up with the skin depigmentation and skin atrophy. If you inject in a tendon, and especially if there's tendinitis, you might rupture that tendon. So that's why imaging comes handy. So what's the advantages of doing it with imaging? It's the accuracy, as I mentioned, is good for deep and complex cases like a GP or a surgeon tried that in the practice, failed, couldn't get into because anatomical variance, because patient had previous surgery, anatomy is changed, so it's used for deep and complex joint. It's diagnostic and therapeutic. Red flag identification, quite often they send me a patient for an injection and I find there's a fracture in the sacrum or something which is causing the pain. Or they're sending it for facet joint injection, I find no, there's a nerve root actually impingement, so the pain is coming from the nerve. So it's also identify and have red flag identification. Reduce risk of complications, so we don't inject into the muscle or a tendon or an artery or a nerve. And especially for a patient with hip replacement, post-surgical, because there's a lot of scar tissue, so you need a guided injection.
1 minute.
Okay. So what are the further criteria for GPs? moderate to severe OA. If you are uncertain, you want to know if the pain is coming from that particular joint, and if a patient is waiting for hip replacement or arthroplasty. Contraindication: uncontrolled diabetes, severe coagulopathy, and prosthetic joints. We have to get very careful with that because we know with cortisone, it might increase the blood sugar in the blood. So you watch the patient for at least 2 to 3 days. Okay. Side effect: there's minor and there's rare. The rare one is transient hyperglycemia, tendon rupture, and infection. How often do we inject? Don't inject more than 3 to 4 times a year, please, because you'll end up sometimes with cartilage damage. So give apart, like at least 3 months apart between, and I'm talking mainly for corticosteroid, 3 to 4 times a year maximum. If it doesn't work, it means it's not going to work. So send the patient to orthoped surgeon or try something else. That's not the problem then. Why do we choose this than that? Steroids, they have shorter effect, but they're accessible. Hyaluronic acid has longer effect, lasts longer, but it's more expensive. Take-home message. So short-term pain relief, it's safe with appropriately selected. It's useful diagnostically. It's not a cure. I get that question a lot from the patient. So does that mean it will cure me? No. It's a temporary relief of the pain. It's temporary relief before your surgery. It's diagnostic to know that this is the part which is causing your problem and your pain. PRP is very promising. Again, what to choose, what medication, and when, it all depends on what joint you want to inject, on the severity and cost, if you can afford it or not, and the goal. Is the goal I'm waiting for surgery, or is the goal temporary relief for a sport person? Thank you very much.